All right. Okay, so we'll start with making this big, like so, and we'll continue. So our first case is a 1-year-old spayed female domestic short hair cat. They say that this kitty has thesis bulbi versus microphthalmia, so basically a small globe on the right side. The globe was not grossly visible on examination, and they didn't have any history beyond that for this patient. So my guess is a rescue kitten with kind of an unknown history before rescue, although they didn't specifically say that. It's worth pointing out in the history how, with this very small globe, they didn't really see it grossly or clinically. Sometimes really significant microphthalmia or thesis can be mistaken for eye agenesis, essentially, because of this sort of phenomenon. It may be kind of buried in the periocular tissue. The other eye has pendulous nystagmus, which is just fun to say, and also ocular hypertension, but no apparent signs of glaucoma. So maybe some slight issues in the other eye, but this is the, mainly affected one, essentially. Um, so at gross exam, this is our ruler down here, and each of these little divisions is a millimeter. So you can see that this is quite a small globe, quite a small hemisected globe here. The globe itself is outlined here. You have kind of some conjunctival tissue or periocular or connective tissue attached. Um, and then one of the main things that you'll notice with this eye is that there's not really an obvious cornea. So we have maybe a touch of cornea on this side here, maybe. But otherwise, the ocular surface is essentially just this brown tan tissue, which is most likely iris. And we'll confirm that by looking at it histologically. The posterior chamber is kind of smallish and there's sort of a haze there. It's hard to make out whether there might be any sort of lens material there or not, but it doesn't really look like there's a recognizable lens. And then the uvea tissue is otherwise kind of folded and distorted. We do have a little bit of folding of the choroid or so in here. In terms of grossly distinguishing between thesis bulbi and microphthalmia, generally thesis bulbi is essentially chronic scarring of the globe, right? It's end-stage fibrosis inside the eye that usually pulls or contracts the eye in. You'll tend to have overt intraocular fibrosis with that and also wrinkling of the collagenous tunic. With microphthalmia, it's usually a relatively unwrinkled eye, just small. So I would still kind of have both on my differential list from this gross view because there's kind of a little bit of wrinkling and maybe some intraocular fibrosis, but the sclera overall is looking unwrinkled. But ultimately, it's kind of potato potato, though, in any case. So that's our gross. Let's take a look at the histology. Hopefully, it'll be nice and easy to do a subgross on this case because it's such a tiny little globe. Mm. Mm. Ta-da! What a cute little button. Here it is, all in one field. So here's our optic nerve right here. This is retina kind of coming in through here, but it's hard to even make out. We'll look at it closer. We've got tapetum here and this sort of folded choroid, just like we saw grossly. We do have essentially no cornea here, and all of this tissue is looking like iris, and we'll look at that closer in a hot second. All of these lovely little folds here are ciliary body plicae. And essentially, these are basically coming into plane of section in like odd angles because this is such a small globe. We're like likely getting some of the plicae coming in from basically like deeper in the block, which is why it just looks like there's a bunch of plicae just sort of filling the posterior chamber and kind of looks a little weird. Bit of a distorted globe. All right. That's our little gonio slice. We'll focus on the main globe. See if we can actually find recognizable cornea for you. It's hard. You kind of can't. So maybe you would believe me if I said that the deep stroma here kind of looks like maybe cornea. The collagen fibers are kind of in parallel organization here, so we might be kind of at limbus or so with the deep corneal stroma still exist in existence. And if we look along that too, there's this really wrinkled and folded up basement membrane. So there is still Descemet's membrane at this level too. But even this area is kind of abnormal. It's vascularized. collagen fibers are kind of looking a little bit thick and disorganized, and then basically there's no cornea. And indeed, we do have this prolapsed iris. So this tissue that's coming through the defect here, it's all iris. Edematous, congested, you've got these big dilated vessels, you've got these big clear spaces in the tissue. It's become our new ocular surface. And while we're here at the limbus, you can see that there's conjunctival epithelium here. We've got little goblet cells here and there, little clearish looking goblet cells. And that epithelium continues on over the iris. And you can still see goblet cells in this epithelium that's sliding onto the iris surface. Let's get a closer look at that. Goblet cell, and it's on top of the iris directly. So essentially, corneal epithelium will heal by sliding over surfaces. And you've got these limbal stem cells at the limbus, which help to replenish that epithelium. And especially if you have kind of exhaustion of those stem cells a little bit, or possibly symblepharon, you can kind of end up with a conjunctival phenotype of that epithelium on what may have been the corneal surface, or what is kind of the new corneal surface in this case. So we have conjunctivalization of the cornea, of sort of the cornea, if you can call it that at this point. And you have reepithelialization overlying this prolapsed iris. The cornea itself really is broadly absent in this case. If we look close to the limbus on some sides, embedded in the episcleral, or you might call it the subconjunctival tissue, we've got these multifocal tubules of epithelium. And these are conjunctival inclusion cysts, also potentially a consequence of symblepharon, or chronic inflammation at a site. Sometimes it can be ectopic tissue or implanted there iatrogenically. In this case, probably the chronic inflammation and symblepharon angle is probably why these are here. So we've got that with the cornea. We'll head into the posterior chamber. It turns out all that kind of whitish tissue is intraocular fibrosis. And if we kind of dive into that posterior chamber area, there really isn't any recognizable lens tissue in here at all. It's kind of gone. And we have an optic nerve that is totally unconcerned. It doesn't know what's happening up front. And if we progress in, we can see that there is still retina. It's very jumbled, atrophied. You have a ganglion cell here, but otherwise the layers are pretty hard to distinguish here. And it's embedded in this fibrosis that's inside the eye and detached. Here's some more of it extending that way. So that's this case. And ultimately, when we're going to land on something and keep talking. Right there. Ultimately, when we have a complete absence of the cornea, the suspicion in cases like this in young kittens, the suspicion is that the cornea became necrotic at some point early in life and is basically just gone for that reason. And most likely this is associated with viral infection in the kitten early in life, so especially herpes virus, but also as published by Coplow, cases of calicivirus can look like this as well. So the idea is that the cornea becomes extensively necrotic early in life. It's just gone. The iris prolapses and reepithelializes. We've even had some cases of cats that go out to like 8 years of age, essentially like adulthood, with this sort of new ocular surface replacing the old. And they only come out and get enucleated if they start to develop pain. But in some cases, they can go quite a ways with this sort of replacement cornea, if as it were. Without having their eye enucleated or anything like that. So that's kind of about it. And we call this feline early life eye disease. Should actually get to the diagnosis eventually. Nope. Okay. Yes. So here's the main diagnosis up front. Usually I do sort of a descriptive thing, or we do sort of a descriptive thing. And then the name of the disease or so is feline early life eye disease. And then some additional things. I ended up calling this thesis bulbi because of the intraocular fibrosis and the way that the choroid at least was wrinkled. You could argue it could be some degree of microphthalmia as well, because we had a rupture early in life and the eye never probably had a chance to get bigger. But then there's the surface conjunctivalization, the inclusion cysts. The lens may be either never formed or maybe more likely extruded. Oftentimes with true aphakia, it can be a lot of congenital anomaly. and then retinal detachment. So that is it. Any questions or comments about this case? Okay. I should say this. There we go. This case is much shorter and mostly cool because of the unusual species. This is a 5-year-old neutered male pygmy goat. The name is adorable and goat related, but I can't give it to you for confidentiality reasons. So you'll just have to imagine your own adorable goat related names. Um, so I'm sure you can come up with some. It's cute though. So 5-year-old neutered male pygmy goat. And they say that there were extensive corneal changes which were unresponsive to neopolydex and terramycin for about a month. Ultimately, they diagnosed extensive corneal fibrosis and they say presumed Hobstria in the right eye and uveitis in both eyes. They did extensive systemic workup, including CBC chemistry, lepto testing, mineral panel, and the only abnormalities they found is a deficiency in copper, zinc, and selenium. Let's see. The patient eventually started responding well, I guess, to neopolydex, and the uveitis was controlled, but OD was progressively buphthalmic, with optic nerve head atrophy, attenuation of retinal vessels, and subsequent blindness, and eventually developed blepharospasm and corneal edema, so they decided to enucleate, presumably because the eye was seemingly starting to become uncomfortable. Um, So interestingly, the other eye had Hobstria about a month ago as well. And so basically kind of similar findings in both eyes, which is interesting. But we'll take a look at this one. So the gross view is pretty uninteresting, I suppose you might say, or underwhelming is the word, I think. We do have a cloudy cornea, which is pretty common in post-fixation corneas regardless, but worth noting. The anterior chamber is kind of deep in this case, and that's kind of it. That's kind of all you can see grossly in this case. Going to be much harder to get a good subgross with this eye, which is quite large. Try getting some of this stuff off this as well. All right. So you can kind of see already that there are these sort of darker pink spots on the back of the cornea here, which are of interest, and we'll take a look at that closer. The limbus is sort of up here or so, but the iris base is way down here. And the ciliary body plicae essentially look like they're coming off the base of the iris, which is a little unusual. So the iris and ciliary body are kind of distorted relative to one another. Over here, there's even more distortion. The iris kind of looks like it's trying to be like a balloon animal or something. We've got like a little face here, a little front leg. But in any case, very severely distorted. We have what looks like ciliary body down here, or maybe base of iris. The limbus maybe starts like way up here. You can see conjunctival fornix way up here. So essentially, we have a really deep anterior chamber because of distortion of the anterior uvea. Um, we'll take a subgross view of the optic nerve, and it's not really remarkable from back here. So we'll take a closer look as we put this up here. So starting up front with the cornea, I swear we're not ignoring the elephant in the room for long. Um, so we have these large areas with breaks in Descemet's membrane. So here we have Descemet's membrane, and then it just abruptly ends. And then that end is embedded in this really robust, deep corneal fibrosis. The cornea itself is pretty heavily vascularized. You can see the stroma here is vascularized. And those breaks in Descemet's, here's the other end of Descemet's picking up again, are ultimately multifocal. Here's another one starting up here, for example. So we have retrocorneal fibrosis overlapping the intact Descemet's, and then if you go far enough, there's eventually this break. And then that fibrosis blends into the corneal stroma and the gap. And there's the other end. So multifocal breaks in Descemet's with a really robust deep corneal fibrosis. Let's go back to that one that we started on, which is pretty particularly distorted. Whoops. So again, to confirm for you the sort of orientation of things, we have maybe conjunctival fornix like up here or so, and limbus starting up here. So we kind of collagen here, which is darker pink and more sort of intersecting streams, and this lighter pink corneal stroma here. So we basically have limbus all stretched out right here. We have this really robust fibrosis where this distortion is, where the iris base kind of originally would have been. And then again, we have this really severe distortion of the iris, sort of a weirdly distorted or misshapen iris, and then the ciliary body and the iris base are kind of displaced away from their usual anatomic location. It's less severe of a distortion on this side, but still pretty distorted. Basically just a really deep anterior chamber here with posterior displacement of the iris base, and then basically the ciliary body itself is displaced from where it usually would be anatomically as well, to the point that it makes it look like the ciliary body plicae are coming out of the iris. Um, so that's what we're looking at up front.
How old was it again?
5. There is some degree of cataract going on here. We'll just briefly take a look at that. So these lovely globules here are Morgagnian globules, and they're essentially just swollen lens fibers. And then you can kind of still make out the lens fiber structure here and here, but then there's this big gap in the middle where it's just this homogeneous pink. That's liquefaction of those lens fibers. Essentially, it's just all liquid lens protein at that site, also part of cataract. And then the lens epithelium is way back here, migrated posteriorly next to the posterior lens capsule, which is very thin. And it's also exhibiting hyperplasia and hypertrophy. So all signs of cataract. We've got a cataract in the scot. And then evaluating the optic nerve and retina on the scot is a little bit trickier. You could maybe believe me when I say that usually in most species, if you draw a line straight across where the choroid is, and then all the way to the other side across an optic nerve, typically the beams of collagen of lamina cribrosa, this pink stuff here, should be level with that. You should be able to draw a reasonably straight line. In this case, there's maybe subtle posterior displacement of that, and maybe the beams of collagen are a little bit closer together. So maybe there's a subtle atrophy, but it's a little bit equivocal, or it's a little bit like not, obvious. And then evaluating
Can you diagnose it as glaucomatous? Sorry.
So they say that they never really got what they would call high intraocular pressure, although maybe a little bit of uncertainty on that. And then they did say that this patient was ophthalmic, um, and let's see, was starting to develop. They said optic nerve had atrophy and attenuation of retinal vessels, and then also blind. So I think clinically the picture ultimately suggested glaucoma. But yeah, it's equivocal histologically, I would say. There are still ganglion cells. You could maybe decide that they're somewhat decreased in number, but again, it's pretty equivocal. So much harder to call glaucoma in this goat. But given the buphthalmia and the clinical signs, it's suspicious for at a bare minimum. So let's go back to this area and start chatting. With all of the features in this goat, the large breaks in Descemet's membrane, it could always be Hobbs stria. It's interesting that they had such a robust fibrosis associated with them. We don't always see that with Hobbs stria, at least in other species. And then in particular, the big breaks in Descemet's membrane coupled with the distortion of the anterior uvea, potential displacement of the iris base and ciliary body from their normal anatomic location with fibrosis in the gap, like we kind of see here. This kind of suggests to us the sequela of cyclodialysis. So we would wonder if at some point the iris and ciliary body tore away from their normal location, and then what we're looking at here is like the chronic consequences of healing after that event. Big breaks in Descemet's membrane, especially peripherally, it can also be trauma induced. Usually with blunt trauma, at least, the force of that blunt trauma tends to distribute to the peripheral cornea. So in terms of trauma-induced breaks, we more often see them peripherally, at least for blunt trauma. Um, so, long story short, the findings in the anterior chamber and cornea of this goat were suggestive of ocular trauma to us. But, difficult to exactly confirm, like, how things might have gone down. And then glaucoma, presumably just due to distortion of the aqueous outflow pathways in this case, although glaucoma is difficult to definitively confirm histologically in this case. Um, so that's kind of the story. And then there's no histologic uveitis. So basically, we define uveitis histologically as inflammatory cells in the uveal stroma. But it's important to note that clinically, uveitis is defined based on aqueous flare, cell flare, things like that, which may not always correlate well with whether we see inflammatory cells in the uvea or not. And that can sometimes lead to a bit of a disconnect. It's also worth noting in this case that this patient has been treated for some time for uveitis, which may also be affecting what we're seeing histologically and why we didn't really see a histologic uveitis. Um, so I think that's all to discuss. And then, yeah, if we're thinking about this as a trauma, it's odd that the other eye was presenting with similar complaints. Technically, you can get trauma to the other eye with the same trauma that may have traumatized this one.
Is it a male or a female?
I believe male. So yeah, I mean, you wonder about headbutting maybe, but
That's what I was thinking. Land with goats.
male
you
neutered.
see that really commonly
Yeah.
with goats?
Yeah,
That was the cause.
yeah.
At
You'd
least
think that they'd
I
have
don't
like
see many goat eyes, but
you think that they'd have enough adaptations essentially to accommodate for the
It
headbutting.
also doesn't mean it doesn't happen.
That's true. It also doesn't mean it doesn't happen.
Okay.
But yeah, I don't know.
Maybe goats. I think all goats would probably have male goats would probably have the same headbutting sort of instincts.
Yeah.
Maybe even more for pygmy goats. They have like a Napoleon complex. But I don't know. I've never made that connection. I don't know if that's a possibility, but it
Yeah,
does look like trauma to me.
yeah, exactly. Um, Basically, it could be bilateral trauma, essentially trauma affecting both eyes. And I will admit that, like, thinking about headbutting springs to mind in terms of like a blunt trauma, but it's hard to be sure. But yeah, an interesting case and an unusual species that we don't always get. So,
I think sometimes we see like really robust fibrosis like this with young animals.
Yeah.
ah,
So I wonder if this goat, like trauma, I agree with, it's very, very suggestive of trauma, but the degree of fibrosis I think of as a young animal thing.
okay.
And so maybe he's had this problem for a long time.
Yeah.
Maybe. Who knows?
Yeah, it's interesting.
I don't know what their durations are.
And the cataract, did it look like poorly formed or
You mean like congenital
did it look like
cataract?
congenital or just a straight up?
I think it looks like a straight up cataract. It just looks cortical to me. Features that might suggest congenital, if you have disruption of the lens bow and often nuclear mineralization, sort of more of like a nuclear effect or a deep cortical effect, could be suggestive of congenital. And I don't know. I don't think we can rule out congenital, I guess, but it looks like conventional cataract. Um, yeah, that is interesting. I think they said so. The duration they said was about 1 month. Unless something like happened more recently that kind of triggered a worsening, which is always possible. But yeah, hopefully everybody heard on the microphone. But Gillian says that she associates robust fibrosis like that with Hobstria, often in young animals. So keep that in mind. Um,
Yeah, Dr. Lee asked to repeat the discussion, but I think
oh
you just
yeah,
did.
okay, yes, good. Uh, it's the Galaxy Quest thing, which is I've got to repeat what the computer said. Um, anyway, that's it. I'm gonna move. We'll show the diagnoses. There you go. And here's next.
Alrighty. Next up, we have an eye from a 12-year-old mixed breed dog, spayed female. The history we got was ventrolateral large uveal mass with partial retinal detachment, 2+ flare, and secondary glaucoma, chemosis, and hyperemia. I'll save the rest of the history for later. So here is the globe hemisected. In this case, we did not actually remove the third eyelid. So since they had a suspicion of a mass, I think the person who was grossing this, who is a mystery, I can't remember who it um, was trying to preserve the surgical margins so that we could evaluate the surgical margins of this case. So we trimmed the lids off, but left the rest of the extraocular tissues attached. So this is the third eyelid here. This is the cornea, which is very opaque. And oh, actually, I think this is the second half of the globe, because we don't have the optic nerve here. So I think a photo was not initially taken of the case. Anyway, so we might have a less than perfect representation of the globe in this hemisection. But for example, like I don't really see the lens here. It might be here. I'm not sure. But the cornea that we do have is opaque. And then we also, it kind of blends with this tan tissue here, which is in the supraciliary and suprachoroidal space here. This is the detached retina. And then we have hemorrhage in the subretinal space and in the posterior chamber. And I think this is the anterior chamber right up in here, which is a little bit hard to distinguish. And there's white tissue on the surface, the anterior surface of the iris. So we do have evidence of a mass in this eye. Um, the gross notes say the iris, ciliary body, and choroid have a tan mass that was extending through the sclera into the orbital tissue. So without further ado, let's jump to the microscopic findings. So here's the tip of the third eyelid, as I said. Here's the cornea, which looks extensively ulcerated. Um, the main event, however, is this hyperbasophilic or hyperpurple area that's affecting the iris in this area, and also the ciliary extends into the ciliary body and into the sclera here. The lens is here in the center, and there's some mineral in it, so there's definitely some cataractous degeneration. And when we move to the other side, the limbal to equatorial sclera is also a little bit more purple than it should be, as is the choroid, the peripheral choroid in this area. The back of the eye is a little bit less exciting, but that mass effect does extend into and expand the choroid on this side and almost reaches the optic nerve head. We don't have the greatest sampling of the optic nerve head in this section. The retina is detached. One of the reasons we can tell that's real from this magnification, at least, is this blob of hemorrhage here. So whenever you have something convincing in the subretinal space, it's good evidence that it's true retinal detachment. Okay, so let's go ahead and jump to higher mag here. So here's our cornea. Oh, I lied. It's not ulcerated. The epithelium is still present here. But the cornea is the least of this problem, dog's problems. So let's go ahead and look in this area. So whenever we have increased purple in tissues, that means there are too many cells or more cells than one would expect. Like an organ like the spleen is purple because it's chock full of lymphocytes and other white blood cells. But certain other tissues should not be quite so pink or purple rather. And this is an example of a tissue that's purple that shouldn't be. And when we go higher mag, the cells that are here that are responsible for that are these great big spindle-shaped cells that are pretty ugly. So they vary in cell size and nuclear size. Here's one that's undergoing mitosis right here. We've got nice metaphase alignment of the chromosomes there. And we also have some that have really prominent nucleoli. So there's a new big old nucleolus in this cell. And there's also quite a bit of necrosis around. So a lot of this dark purple diddly dot stuff is pycnotic debris, chromatin, etc. So we have a pretty ugly population of spindle cells. When we see them, sometimes they form these streams, and in other areas they look like they're more in cross section. So that's probably a stream that's cut in a different plane of section. Um, and even from a lower mag, you can really just appreciate how pleomorphic they are, which is typically a bad sign, a sign of malignancy, I should say, to be more specific. Let's just wander into the iris stroma itself. So here in the iris stroma, we have the blood vessels of the iris stroma, and then we have, unfortunately, neoplastic cells in the lumens of the iris stromal blood vessels. And these cells have similar features to those that we were looking at in the sclera and the peripheral cornea. So this is evidence of vascular invasion. And then we have to decide whether we think these cells arrived in the eye from elsewhere in the body. So they're arriving in these blood vessels versus developing in the eye and exiting the eye in the blood vessels. Honestly, in this case, I think it's both. And part of the history that I didn't share with you is good evidence of that. So as we move out into the sclera, I think this is probably a big vessel that's chock full of cells. The other side of the sclera is a little bit more convincing, so I'll show you that in a moment. Let's just move back for a sec. So there are vast areas of necrosis. So all of these areas where it's more pink than purple are just areas of necrosis. So they're not that exciting to look at higher magnification because the cells don't have any structure anymore to really try to evaluate. So we can move back here into the choroid, and it's kind of a similar story to what we were looking at first, where the neoplastic cells are spindle-shaped. Once again, they are in choroidal blood vessels here and spilling out into choroidal stroma. So fairly pleomorphic. You can see some pretty big nuclei. Here's a great big nucleus with a great big single nucleolus. Here's a great big nucleolus here. Here's a mitotic figure. So yeah, this is just a pretty ugly population of neoplastic cells. I wanted to show one thing over here. So one of the things that I thought was interesting is that you can see where I think neoplastic cells are coming right up into the choriocapillaris, which is the blood vessel bed that feeds the basically the retina. So they feed the retinal pigmented epithelium, which is what's here, and because the retina is detached. So you can see those neoplastic cells kind of moving right on up into that choriocapillaris. So that is a good indication also that this is a tumor that originated elsewhere in the body and arrived via the vasculature. Um, so keep that in mind because we're seeing the blood vessels in the blood, we're seeing the neoplastic cells in the blood vessels that feed the retina. So that is where the oxygenated blood would be arriving in the eye. However, up here, we are looking at the veins of the scleral venous plexus. And the scleral venous plexus is where eventually the aqueous humor will flow into. So the aqueous humor is in the anterior chamber. It flows out through the trabecular meshwork, which is right in this area. It's sort of, once again, obscured by neoplastic cells. And then it exits the eye via the angular aqueous plexus that then joins up with the scleral venous plexus. So the fact that we have neoplastic cells in the scleral venous plexus also means that they're exiting the eye because that's an exit point for the eye. So unfortunately, this dog has neoplastic cells that have arrived in the eye and now are also leaving the eye. So those are the main findings of the eye and the main event. The cells do occasionally carpet surfaces. So these cells that are on the surface of the lens are neoplastic cells, in my opinion at least. And whenever we see carpeting in the eye, we think metastatic disease, which I'm already pretty convinced of. But this pattern of carpeting is spot on for at least metastatic disease to the eye from the ophthalmologist and ocular pathologist perspective. As I said, at low mag, there was some mineral in the lens or disruption of lens material. So we have some cataractous degeneration. We've got a few little more ganglion globules here. So we've got some cortical lens fiber degeneration at least. The retina is detached, as I said. At this point, I would say as far as the actual retina itself goes, in order to confirm that, we have shortening of the photoreceptor inner and outer segments. So some people call these the frilly frills. The pink frilly frills should be longer, and they're sort of short and clubbed here. So that's an indication that the retina is truly detached as well, because those are the things that will begin to degenerate the most quickly after retinal detachment. So I will now share with you the rest of the history for this patient, which doesn't actually help all that much figure out what this actually is. But so they say prior to enucleation, the dog had pre-op chest rads, and they found a large mediastinal mass. They did aspirates of the mass, which were inconclusive. Um, and the dog also has something going on in the liver and spleen, and those were FNA'd as well, and they just say that it was benign. So I'm not sure exactly what those findings were. But the statement that they made was a little bit confusing to me, but they say that being that lymphoma was not diagnosed on cytology of the mediastinal mass, they suspected thymoma. Um, which is odd because thymomas they're a neoplasm of the sort of epithelial component of the thymus, and you have a significant proliferation of the non-neoplastic lymphocytes. So I would think that FNA of a thymoma should yield at least a lot of lymphocytes, and they didn't really say that. They said it was inconclusive, but anyway. So this, in my opinion, is not consistent with the thymoma. We have a population of spindle-shaped cells that are really more consistent with some sort of sarcoma, which is not suggestive of thymoma in this case. So I suspect this dog had something else going on that either originated in the mediastinum or also metastasized to the mediastinum from elsewhere in the body. So in my opinion, this is a metastatic sarcoma of some sort. And I wasn't really able to pin it down any more than that, personally. If anyone else can, speak up. Um, so I called it a poorly differentiated malignant metastatic neoplasm with vascular invasion. I didn't come out and call it a sarcoma there just because I wanted to keep malignant melanoma on the differential list, and it is technically a sarcoma, but it feels weird to call it that. So anyway, so here are my differentials. So sarcoma, not otherwise specified, malignant melanoma, histiocytic sarcoma, which was less likely in this case because we didn't really have that good histiocytic phenotype of large cells with multiple nuclei and things like that, or some sort of anaplastic carcinoma. I didn't want to entirely rule out a thymoma in case that is actually what this is. I was like, well, this would be one heck of an anaplastic carcinoma.
Yeah.
But I don't know.
And it's very hard. This spot is complicated, right? Because on our end, we could spend a lot of money doing immunohistochemistry and not get anywhere much more conclusive than where we are right now. Or the clinicians and the owner might want to use that money to do some systemic workup.
Yeah.
Sometimes I do, and I know other people do also here in the lab, just by conversation, feel bad about not trying anything further and just saying,
Yeah.
the ball's on your court right now, deal with it. But it's complicated because at the same time, we don't want to mislead people in terms of how far we can get with the diagnosis by doing just more tests, you know.
Yeah, I did suggest if we did pursue IHC to start with the basics. So I suggested vimentin and cytokeratin, which would differentiate mesenchymal from epithelial, sort of, sometimes.
Yeah, and then you got a pretty differentiated carcinoma, right? It might be
Right, yeah.
positive for both, and
Yeah.
then you'd spend $200 and you're in the same spot.
Yeah.
And
Yeah.
couple 5 days later, and then we can try this, and that.
Yeah. Yeah. So anyway, I don't have any more follow-up on this patient.
Doesn't bode well though.
No, I think this is bad news for this dog. Okay, on to something less dire. Well, not for the eyeball because we have it in a jar, but for the rest of the dog, probably okay. All right. This is an eye from a 10-month-old intact male mixed breed dog, which came with an interesting history. Kind of brief. They say acute corneal perforation from suspected spider bite or some other insect or animal during a walk at night with the owners. So the duration, they said hours. So they enucleated very shortly after this happened. And let's see here. They say ulcer slash perforation decompensated within hours into severe keratomalacia of the entire cornea. So here's the globe. And so they decided to nucleate. So here it is. Here it is, front on view, which basically shows that there's opacity to the cornea, but it's much more dramatic when you hemisect it and look at how protruding that cornea is. It's also very thick, which is an indication of severe corneal edema. And when we see severe corneal edema like this, we call it hydrops. Corneal stromal edema. So, and that was it. The rest of the globe looked pretty good. It was from a 10-month-old dog with no other known ocular problems. So we have a nice normal looking optic nerve here. The retina and the choroid look pretty good. The lens looks pretty good. The iris looks pretty good. There is a little bit of hyphema, so some hemorrhage in the anterior chamber. And we did not really see a distinct corneal perforation site, grossly. So I got the initial slide and then ordered a couple deepers. So we'll just go to one of my deepers in part to save a little bit of time. Okay. 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 So cornea to the left there. And that's where we're going to spend all our time on this case is the cornea because the rest of the eye is pretty normal. So we do have true ulcer in this case, I promise. So the corneal epithelium is absent from the surface of this cornea. There is a little bit of basophilia here, so there are some islands of corneal epithelium remaining. And then we also have the corneal stroma is very pale in the center there. Here is more normal corneal stroma, so it should be this hue, it should be about this thick. And when we go axially or centrally, it's very pale and very expanded. So that's that corneal edema I mentioned. Also, we have this sort of deep corneal stromal cavitation. And then there's some hemorrhage in the anterior chamber. And there's also a hemorrhage in the iris stroma. Okay. So we'll just start here. So that corneal epithelium is present here and it looks relatively normal. And actually, let's start on the other side, start with normal. Relatively normal corneal epithelium, stratified squamous epithelium that should not be keratinizing, which is true in this case. It is not keratinized over here. We do have an increased number of inflammatory cells in the corneal stroma, which are neutrophils, I believe. Yeah, so all these little guys are neutrophils. And these spindle-shaped cells are probably the keratocytes, which are the native stromal cells of the corneal stroma that are getting a little bit hypertrophy. They're getting a little bit active because something is awry, has gone awry in this cornea. So as we follow the epithelium, it does eventually become discontinuous. So here it is present. And then you can see a bunch of neutrophils in the epithelium right here. And then as we follow it, it just disappears. So corneal epithelium is gone. So yes, true corneal ulceration, as they mentioned clinically. And then a bunch of neutrophils, both in the epithelium, in the stroma, and sort of accumulating on that exposed corneal stromal surface. We do have little islands of epithelium, so they are trying their best to cover this area. I think probably because of the great expansion of the cornea, um, the number of cells just had to sort of try to spread out to cover the defect. But we do see little islands of them. And in order to confirm keratomalacia or collagenolisis, we look for islands of epithelium that are sort of drowning in the stroma. And we don't really have that here. We do have like one individual keratinocyte here. So I think while I think this might be collagenolitic, it's a little bit hard to fully confirm it histologically. But something, I mean, it's very interesting appearance. The corneal stroma is almost gone. It's hard to pick out any of those collagen bundles of the corneal stroma in this area. Um, so those are the main findings. Descemet's membrane is discontinuous. And actually finding it might be hard. I think that's fibrin. Here it is. Here's Decimase. And actually, there's the end of it right there. So Decimase is broken, and we have this dense layer of fibrin with some enmeshed red blood cells that sort of forms a pseudo-Decimase membrane. Anyway, so, and then as I said, the other most significant finding is the hemorrhage in the anterior chamber. So that's hyphema. And then also the iridoral stromal hemorrhage as well. So, I was able to confirm some of their clinical findings. Not all of them. I couldn't really comfortably say that this was keratomalacia. But there's certainly really severe corneal stromal edema. There is a break in Decimase membrane, which could be due to trauma, like penetrating trauma. I don't personally think a spider bite would do that. I could be wrong. I guess one possibility is a spider bite of some sort that would have led to severe corneal stromal edema and then leading to break in Decimase, but I find that hard to believe too. So another possibility in this case is a snake bite. And uh, Collagenolisis, corneal stromal edema, and hemorrhage are common and have been reported in a paper that was published with Coplow.
Where's the dog from?
This one's from Georgia. Um, so snake bites can lead to various combinations of all of those things. So corneal stromal edema and hemorrhage. I honestly don't know what this is. I think that an envenomation of some sort could have led to these lesions. And that's all I can really say. So either of a snake of some sort or some sort of insect, but I feel like an insect is less likely, but I don't know.
Yeah, if not for the iris stromal hemorrhage, I think, which I think is a very finding. I don't think we'll be able to tell much beyond just trauma, right? Like a blood trauma with a ruptured Decimus membrane. But the stromal hemorrhage is interesting because it's not something you would necessarily expect from traumatic event like that.
Yeah.
Very cool.
Yeah. Anyway, so
Makes you want to probe a little bit further how the owner got to that suspicion of
yeah, right.
fight or bite or something. What happened?
Yeah.
Especially at night.
Yeah.
All right. Looks like probably time for this case. A little more complicated, so I think it'll take me the full time. So this is the globe from a 7-year-old male castrated Great Dane. In the history that was provided, was this eye did have glaucoma. They described it as blepharospastic, ophthalmic, said there was severe injection and severe diffuse corneal edema. So they were unable to evaluate inside the globe. They said the duration of this problem was 2 weeks, and then this dog was otherwise healthy with normal pre-surgical blood work. So here is our gross hemi section of that globe. We can't really, it's a little bit hard to see the full quality of the cornea, but it does look a little bit cloudy. But there's a lot going on within the globe here. So there's kind of this pale red, kind of hemorrhagic exudate within the anterior chamber, posterior chamber, and in the vitreous, maybe a little in the subretinal space as well. Our retina is detached, maybe looks a little bit thickened in some areas. And then we had also described the ventrociliary body, which is here, as being a little bit thick as well. And then also there's kind of like these little tan, I guess plaques is probably the best word to describe it here, on the choroid. And those are the main gross findings. So we will move to the histology. Start with the original section. And I will do my best to do a subgross. Like I always have the shakiest hands when I do this. Okay. Okay, so cornea is up top. I'm gonna get it more in view for us. There we go. So here's our cornea. It's not very exciting. There's a little bit of vascularization, which they describe clinically. Here are our iris leaflets. One of them is pretty distorted. It looks like almost like a little nubbin. This one is a little bit more elongate, looks more like an actual iris profile. And we can see that there's more purple in the stroma where there should not be purple. So there's some sort of cellular infiltrate. And then there's also this membrane on top of the anterior iris surface. So we can go closer to look at that. That increased cellularity is also within the ciliary body. And as we move back to look at the choroid, it's a little hard to make out from here, but there's also some cells in the choroid. So there's a uveal infiltrate. As we saw grossly, there is hemorrhage within pretty much all the chambers, mostly within our vitreous here, this chamber. And then our retina is detached, as we saw grossly as well. The lens isn't very exciting. We probably won't spend too much time on that. And then here's our optic nerve head, which is kind of distorted due to this retinal detachment. And then here's a black Sharpie mark that I made. We will come to that eventually, but it's not a lesion. Okay. Go. All right, so cornea is going to be on the right, posterior segment will be to the left. Really don't need to spend too much time on this cornea. There is vascularization. Maybe there's a titch of inflammation within the stroma, kind of just scattered. Neutrophils here and there. So there's a neutrophil, there's a neutrophil. Otherwise, it's mostly just vessels, which is pretty nonspecific. As we move to the iris, first there's that membrane that's sitting on top of the anterior aspect of the iris. Here's maybe the anterior margin where all these melanin-laden cells are. And then we have this fibrovascular membrane, which is pretty robust, lining the surface. And there's areas where it looks like it's crossing the iridocorneal angle, causing anterior synechia. So we have a great reason for glaucoma already in this case. And then looking, oh goodness, within the iris stroma itself, mentioned that there was that increased cellularity, and it's just a ton of lymphocytes and plasma cells. So we have a pretty marked lymphoplasmacytic uveitis, which is also somewhat nonspecific, probably the most common inflammatory pattern we see in the uvea. And then that membrane does look like perhaps it's ascending over the anterior lens capsule. So there's a bit of a posterior synechia on this side. Over here, same changes, just that membrane is kind of grabbing on to the margin of the iris and pulling it forward. So we have this ectropion uvea. It's kind of making this funny little nubbin of an iris. And then as we move back, we have similar cells throughout the uveal tract. We don't need to look at them too closely, just more lymphocytes and plasma cells. As we look more in the posterior chamber in the vitreous, not only is there hemorrhage, there is a little bit of an inflammatory exudate as well. So we have some little clusters of neutrophils, and these big guys are macrophages. Here's our macrophages here. Sometimes they get this like really foamy quality to their cytoplasm. And then just to show, here is our choroid. And again, there's just a little bit more cellularity. So there's just more lymphocytes and plasma cells. So we have a panuveitis. And as we move back, I'd point out those plaques grossly, which is likely this is the correlate to them. There's kind of just these little cellular aggregates on the epichoroidal surface. And then we can move on and look at our retina. As I mentioned, is detached. There are areas where it maybe even looks torn. There's like a weird kind of blunt rounded end right here. There's areas of full thickness atrophy. I can go on closer. Where we kind of have jumbling and loss of the retinal layers. There's other areas we can kind of make out. Maybe there's an outer nuclear layer, an inner nuclear layer. So we have some retention of the retinal architecture. And then there is an inflammatory infiltrate in here as well, kind of just lymphocytes and plasma cells, a very common recurring theme in this particular eye. But then when we look at the ventral retina, which is also detached, let me move out a little bit actually this way. So here's our detached ventral retina. As we move centrally, there's kind of this extra layer sitting on top of it on the epiretinal surface. So there's this kind of fibrovascular membrane. And within that membrane, again, just more lymphocytes, plasma cells, kind of more of these weird foamy macrophages. As we look around, maybe around this very helpful dot that I've made, get good resolution. There's another cell type in here. A little hard to make out on this screen at least, but there's these guys that have these bilobe nuclei. There's more of them, and they have brightly eosinophilic cytoplasmic granules. So these are eosinophils, kind of just floating around in this membrane, which is weird. We don't tend to see eosinophils very commonly within the eye. And their reason, at least in this slide, is not evident why they're there. So initially I did a GMS to make sure there wasn't any fungal disease. Sometimes kind of these little plaques of inflammation on the epichoroidal surface we can see with fungal infections. That was negative. So I released a report that was, I don't know how helpful it was, just providing some vague differentials saying, hey, maybe consider testing for systemic infectious disease. There is retinal detachment and hemorrhage, rule out systemic hypertension, but this is overall just like kind of this vague inflammatory lesion. And it's hard to say why it's there. So I ended up getting deeper sections, which isn't usually very fruitful. But in this case, it was, which is why I'm showing this case. I don't really have much else to add in terms of the changes in this eye. There's still just this inflammation, there's hemorrhage within the eye, but fortuitously within the posterior chamber / vitreous, there's this little guy. Oh my gosh, let me get one closer. Come here. Oh my gosh, I'm gonna go even one closer. There he is. So we have a cross-section through a metazoan parasite. More specifically, this is a nematode. And to give a proper board-style description, there's a few features that's highlighting beautifully. So it has this smooth eosinophilic cuticle. This layer here, this is the musculature. So it's coelomyarian, polymyarian musculature. These structures on either side here are the lateral cords, which are quite prominent. And then this is a cross-section through the digestive tract, probably the esophagus. It often has this kind of triradiate appearance to it. And this is the only section that I have of this nematode. It got lost in deeper sections. I cut in more of the globe and could not recover any more cross-sections through this nematode. But kind of cool. So this would provide a great explanation for why there are eosinophils in this eye. It could provide an explanation for why there's just this raging panuveitis, why there's hemorrhage and retinal detachment, just aberrant migration of a nematode parasite. I'm not quite sure who this is, unfortunately. I'll go closer while I talk.
Oh, just need a good explanation how you got there.
Yeah, and how he got here even too. There's a lot of questions for this guy that he's not answering. Unfortunately, yeah, we're pretty rostral in the section, so there's a lot of identifying features that we don't have here in this particular cross-section. So in the end, just said, yeah, there's a nematode parasite here, definitely do a fecal, do empiric deworming. There are reports of dirofilaria, usually like the L4, L5 larva migrating through the eye aberrantly, so definitely check heartworm status in this dog too. The features of this do fit heartworm, however, they're not by any means specific to it, so it could be someone else as well.
And it's such atypical because it's an adult worm, which is, or a
Big?
or
I mean,
a-
it's
or,
big.
let's see, it's not a larva, let's put it that way, which would be the
Yeah.
early migrating larva. That's what you usually see.
Yeah, like the little Toxicara
Yeah.
guys. Mhm.
Like
Yeah, it's a big
and
one.
floating in the chamber like that is another weird
Mhm.
presentation, but
Yeah,
very cool.
kind of a strange one,
Mhm.
but yeah, satisfying finding at least. So deeper sections do work sometimes.
And such a well preserved nematode. This is beautiful.
Yeah, I love it.
Yeah.
Move to our
This is the type of case you really warm up to over time.
Hey. The pun from Dr. Kleinman's, I'll name her, was this is the type of case you warm up to over time. Warm up to. All right, and here are my diagnoses. This is a super long list, just kind of endophthalmitis with intraocular nematode parasite is kind of the bottom line for this one. All right. And if there's no questions, thoughts, comments,
Kelsey Greg said
yeah.
something here that I think a mark of dirofilaria
Mhm.
is a very small intestinal profile, which doesn't look like what we have here. It's kind of the opposite.
Yeah.
Robust.
Even in the esophagus, because I wonder if this is more rostral in the parasite, but admittedly, yeah, my understanding of parasite features is always a little bit poor.
No, I think you did a great job, and I think it is weird limits of how we can recognize that this cross section here, especially because it disappeared, right?
Yeah.
I had a similar case where like you get a globe and you're like, why are all these eosinophils here and what is going on here? And then
Makes it think.
you're like, maybe I'll go deeper, and then you find something, you're like, oh my God, it's a worm. Yeah, like so crazy.
Yeah, it's pretty cool.
Yeah.
All right, cool. With that, I think we're at time. So thank you, everyone, and we'll see you in 2 weeks.
So basically we have these 30 points.